Hi everybody, I am Dr. Pradeep Shenoy, consultant rheumatologist addressing you from Amrita Center for Rheumatic Diseases, which is located opposite to KMC Attawar in Bangalore. In this video, we look into few facts about psoriatic arthritis. Before 1970s, it was very difficult to differentiate between rheumatoid arthritis, psoriatic arthritis, and osteoarthritis. What I mean by osteoarthritis is nodal osteoarthritis, which typically occurs in the distal interphalangeal joints. So, way back in 1973, Moll and Wright laid down the classification criteria for psoriatic arthritis. This was based upon the presentation pattern of the arthritis. According to them, less than 5% had arthritis mutilans, 5 to 10% of the patients had psoriatic spondyloarthropathy, 10 to 15% of the patients had DAP predominant psoriatic arthritis, 15 to 30% of the patients had asymmetrical oligoarthritis, and remaining had rheumatoid arthritis like symmetrical polyarthritis. This classification criteria was fair enough, but was not sufficient to do clinical research. It was not sufficient to define the early illness, and it was also not sufficient to diagnose the disease before the onset of skin disease. So, in 2006, Casper criteria came into existence. This had two domains. One domain was entry level domain and other domains were subdomains. In the entry level domain, they had inflammatory spinal disease, peripheral joint disease, and enthesis. And the patient, if had only one or three of them positive, only then they were considered for the subsequent 5 domains. Remaining 5 domains were skin psoriasis, nail changes of psoriasis, psoriatic dactylitis, absence of rheumatoid factor, and bony changes of psoriatic arthritis. Coming to psoriasis, if there was psoriasis at the time of diagnosis, it was scored 2. If there was a family history of psoriasis in blood-related relatives, that is 1 or 2 relatives, then it was graded as 1. Past history was again labeled as 1. Coming to dactylitis, it was present at the time of diagnosis or it was documented before, it was scored as 1. And nail changes, if present, for example, if they had pitting, onycholysis, subangular hyperkeratosis, etc., it was scored as 1. Absence of rheumatoid factor, which was done by standard nephelometry or turbidometry, if it was negative, it was scored as 1. And X-ray changes of psoriatic arthritis, that is bony proliferation, if it was present, it was labeled as 1. It was scored as 1. So, apart from the entry level mandatory criteria, if the patient had more than or equal to 3 scores in the subdomains, only then the patient was considered to have psoriatic arthritis. This criteria was sufficient to diagnose early psoriatic arthritis before the appearance of skin disease, and this was sufficient to do clinical trials. The sensitivity of this criteria, that is Casper criteria, was 91%. It is 91%, and specificity is 98%. So, this helped us in including other type of psoriatic arthritis like Sappho syndrome, which stands for synovitis, acne, pustulosis, hyperostosis, and osteoitis, and psoriatic onychopachyderma periostitis. These two atypical patterns into psoriatic arthritis. So, this was very important. And coming to the treatment modalities, the enthesitis responds better to TNF alpha agents and more so to tofacitinib and upadacitinib because tenosynovitis have synovium in it, but enthesitis does not have synovium in it. Enthesis does not have synovium. So TNF alpha conventional drugs like Remicade acts less here. Newer molecules JAK1 and JAK3 inhibitors act better on the enthesis. And looking into the periosteal reactions, new bone formations that happens in the psoriatic arthritis, scientists thought that apart from the traditional pathways, some other pathways might have been playing a role in this. Subsequently, this led to the recognition of IL-17 and IL-23 pathways, which were linked with the WNT5B pathways. So this explained the new bone formation in psoriatic arthritis. So psoriatic arthritis is quite a distinct disease from rheumatoid arthritis and osteoarthritis. Initially, the drugs which were used in treating refractory psoriatic arthritis were TNF alpha blockers, but psoriasis was a part of metabolic bone syndrome in many patients. So they had obesity. Patients who were obese were refractory to TNF alpha agents. And other predictors of TNF alpha resistance was longer duration of the disease, spine disease involvement from the outset, periosteal reaction in the spine, etc. So further research led to the intervention of other molecules into the existence. So ultimately now we have etanercept, Remicade, upadacitinib and tofacitinib in the armamentarium to treat psoriatic arthritis. But it is very important to differentiate psoriatic arthritis and rheumatoid arthritis because rheumatoid arthritis has got more of extra-articular manifestations, vital organ involvement like heart involvement, lung involvement, and later complications like amyloidosis, which are more common in rheumatoid arthritis, and they are not well documented in psoriatic arthritis. And skin disease of psoriasis is quite distinct from the articular manifestations of psoriatic arthritis. Gene responsible for skin psoriasis is HLA B38 and B37. In case of articular manifestations, it is HLA B27. So put together, psoriatic arthritis is very interesting. There is skin changes, articular problems, nail changes, dactylitis, enthesitis, last but not the least, acute anterior uveitis. So all these symptoms require attention at a time. So a rheumatologist should look into all this spectrum as a whole globally, and not to worry, there are sufficient drugs to handle this. I hope this short reel will be useful to you. Thank you. Thank you very much.